afternoon, everyone, and welcome to today's Public Health Ontario Rounds presentation on preventing the silent pandemic, antibiotic stewardship, and COVID-19. My name is Jenny Robertson. I'm a manager at PHO, and I have the pleasure of moderating today's session. Before we start with today's presentation, I'll mention a few housekeeping items. Zoom allows attendees to have the ability to customize your own view. You can do so in the right-hand corner of your own screen. Please use the Q&A pod if you have questions during the session. We will save questions until the end of the presentation. The chat pod has been disabled to limit any distractions during the presentation. If at any point during the session you experience any technical issues, please email events@oahpp.ca. I would like to state, as the moderator of this session, I do not have any potential conflicts of interest to declare. It's now my pleasure to introduce the speaker for today's presentation, Valerie Lung and Bradley Langford. Valerie is the Antimicrobial Stewardship Program Lead at Public Health Ontario, where she works with a multidisciplinary team and external partners to advance antimicrobial stewardship across the healthcare system. She is also a clinical pharmacist at Michael Garron Hospital, Toronto East Health Network, where she is involved in local quality improvement initiatives. Bradley Langford is a pharmacist consultant in the Antimicrobial Stewardship Program at Public Health Ontario. He is also a lead antimicrobial stewardship pharmacist at Hotel de Shaver and Rehabilitation Centre in St. Catharines, Ontario. Brad is a board certified infectious diseases pharmacist with practice and research interests in antimicrobial resistance, as well as behavior change interventions in antimicrobial prescribing. Now over to Val.
Hi, everyone, and thank you for joining. I know this is a very busy time. So I'll be talking, Brad and I will be talking about the topic of stewardship and COVID-19 today. And I'll talk about some of the work that we've done in terms of rapid review and meta-analysis on the topic. And then Brad will talk about some of the more practical implications of what we've learned. But before I launch into it, I do want to acknowledge that this has been and continues to be a huge team effort. And I want to acknowledge the study team, which includes Miranda So, Sumit Rebarden, Duncan Westwood, Jean-Paul Soucy, Derek McFadden, and Nick Daneman. So today, the objectives of my talk, mine and Brad's talk, is to explain the potential implications of COVID-19 to antimicrobial resistance, or AMR, discuss two rapid review and meta-analysis and the findings on bacterial infection in antimicrobial prescribing in COVID-19, and finally to discuss the antibiotic stewardship strategies at the patient and population level. So just to get us started, I wanted to just poll you to see what you think about what will be the net impact of COVID-19 on antimicrobial resistance. So do you think it will increase AMR, not have an impact at all, no change, decrease, or unsure? I'll just give it a minute for you to vote. Okay, hopefully everybody has had a chance to vote. Maybe the results could be pulled up. Okay, so interesting. So 3/4 of you think that it will result in increased AMR, and then others are sort of in the other categories. Okay, so we'll see what you think after this presentation. So you may have noticed that AMR has received some headlines in the press, in both the lay press and scientific media, as a potential threat as a result of COVID-19. And this is, there's lots of factors, but largely based on the concern of potential antibiotic overuse, resulting in selective pressure for AMR. The reality, though, is that antibiotic overuse may just be one of the various factors that could impact AMR in the area of COVID. So there's actually quite a lot of debate about the directionality of AMR, that is whether it will increase or decrease as a result of COVID-19. And on the one hand, I think we all recognize that some factors might actually be working in favor of reducing AMR, at least in the short term. And specifically public health measures such as physical distancing, hand hygiene, that will help reduce transmission of AMR organisms. And then things like reduced influenza rates and changes in healthcare utilization, such as reduced elective procedures, might actually reduce antibiotic prescribing. And in fact, early data from multiple jurisdictions, including at home here in Canada, have shown that antibiotic prescribing in the community has actually decreased during the pandemic, likely due to changes in care seeking for respiratory tract infections. But on the other hand, there are several significant factors that might drive AMR upwards, especially in the long term. So specifically, there is concern that bacterial co-infection in patients with COVID-19 will increase antibiotic use for a couple of reasons. One is that it's very hard clinically to differentiate between bacterial and viral etiology empirically. And then secondly, historically, with other viral infections like influenza, the risk of bacterial co-infection is known to be high, up to 30% in critically ill patients. So it's not unreasonable or uncommon that you'll see that antibiotics may be used in patients, even though we know COVID-19 is a viral disease. To add to this, COVID-19 has disproportionately affected regions that were already historically struggling with AMR, so that could further exacerbate the problem. And then I think we all recognize that COVID has been a sort of all hands on deck situation where many of us are diverted to do different activities. And so people that are normally dedicated to IPAC surveillance activities and stewardship activities, have been doing other pandemic-related work. So, maybe not focusing on some of those activities as much. So as you can see, based on some of these factors, the overall impact of COVID on AMR in the long term isn't straightforward to predict, but since our group is specifically interested in the stewardship aspect of the equation, we decided to take a closer look at the very first bullet there under will AMR increase, in that really trying to understand the prevalence of co-infection and antibiotic use in patients with COVID. So to get at that, we decided to take on a couple of rapid reviews. One focusing on determining or estimating the prevalence of bacterial infections in patients with COVID-19 and to try and identify the most common co-infecting respiratory organisms in these individuals. And then a second rapid review around more details about the prevalence of antibiotic prescribing and trying to think about the predictors of antibiotic use in patients with COVID. So to do that, we again developed two rapid reviews. They are very similar, but with a slightly different focus. So the methods were very similar. So the inclusion criteria were studies evaluating people with confirmed SARS-CoV-2 infections. And we looked at all healthcare settings and age groups, excluding, small case studies or case series of less than 10 patients and review articles. For the co-infection rapid review, we wanted to make sure that the studies indicated the number of patients with respiratory bacterial infection plus or minus bacteremia. And for the antibiotic prescribing review, we only included studies that indicated the number of patients prescribed with antibiotic therapy. The search methodology, we had help from a medical librarian information specialist, and you can see here the dates of the searches. So the first search was until April 2020, and the second one was until June. And so we use broad search concepts, and we also registered the protocols with Prospero, which is an international database of prospectively registered systematic reviews. For the primary analysis, for the bacterial infection rapid review, again, because we wanted to understand the overall prevalence, that was our primary analysis. But we also stratified by co-infection. So co-infection we would define as on initial presentation, where secondary infection was defined as sometime during the course of the illness. So classically nosocomial infections or hospital-acquired infections that were respiratory in nature. And then we also stratified by severity. For the antibiotic infection rapid review, again, our focus was more about the details of antibiotic use. So of course, we estimated the overall prevalence of antibiotic prescribing. We also then stratified by region, severity of disease, also the month of study completion to see if there was some kind of trend over time, and then stratified by age group. In terms of statistics, we reported the proportions of patients with bacterial infection or antibiotic prescribed, and this we used a random effects meta-analysis. We illustrated the results using forest plots and assessed heterogeneity using I-squared statistics, and then undertook meta-regression to identify predictors of co-infection and predictors of antibiotic prescribing in COVID-19 at the study level. So first I'll describe some of the co-infection rapid review results. So here's the study flow. We identified just over almost 1,900 studies from the search, and these studies were carried out between December 25th, 2019 and March 31st, 2020. Finally, 24 studies were included after we assessed them for eligibility criteria. So out of the 24 studies, the vast majority were conducted in Asia and were mostly in hospitalized patients, with some specifically on critically ill group. Most of the studies were on adult patients. And with respect to co-infection, 11 studies explicitly defined co-infection as on presentation, whereas 6 were implicit, so didn't really say either. And so we classified that as co-infection versus 7 studies that identified infections as being secondary. You also see the breakdown of the bacteriological testing method here. So overall, in the random effects meta-analysis, bacterial co-infection was identified in 3.5% of patients, whereas bacterial secondary infection was identified in 14.3% of patients. So when you pool all those studies together, this translated to roughly a 7% of patients with COVID-19 with a concurrent bacterial infection. When stratifying patients by population, which we use as a proxy for disease severity, bacterial infection was 5.9% in all hospitalized patients, in contrast with 8.1% in critically ill patients. So while bacterial infection is less common in hospitalized patients on wards versus ICU, both were less than 10%. In terms of specific bacterial co-pathogens, unfortunately, the number of studies reporting this was low. So 11 out of 24 studies reported specific species, but this only represented less than 14% of patients included in our review. So although you see a breakdown here, it is really hard to interpret given the low numbers. Additionally, since we intended this to be a living review, we updated the data to June 2020, and this is all available to you on the Toronto Antimicrobial Resistance Research Network, TARN website, where you can look at it in more detail. And special thanks to JP Susi for developing this dashboard to visualize the data. As part of this rapid review, we also had a high-level look at antibiotic prescribing prevalence, which was high, so 72%. And this was often broad spectrum, but very few details were available. And being antibiotic stewards, this of course caught our attention because of the low co-infection rate. And therefore, we decided to do a deeper dive into the antibiotic use aspect, which led us to our second rapid review on this topic. So very similar in terms of the flow. Now, this is updated to June 2020, so the number of studies increased and the number of studies being included also increased to 154. This again was specific to antibiotic prescribing, so slightly different inclusion criteria. The results, overall, the usage was almost 75% of patients with COVID-19 received at least one antibiotic in the study. And this was more common in older adults and those with mechanical ventilation. Antibiotic prescribing was lowest in the mixed inpatient outpatient setting at 59%, followed by inpatient hospital setting at 75%, and then highest in ICU setting at 87%. 28 or about 18% of studies provided data on antibiotic classes that were prescribed. The most common here you can see are fluoroquinolones and macrolides. However, this differed based on the geographic region that we were looking at. Additionally, there was a trend towards reduced antibiotic prescribing as the pandemic progressed. Studies ending enrollment or follow-up in January 2020 had the highest antibiotic prescribing at 86%, whereas studies ending in April 2020 showed lowest at 63%. So in summary, we found that despite a low bacterial co-infection rate in both rapid reviews, antibiotic prescribed was well over 70%. And so there's definitely room for improvement. We found that geographic region didn't really make a clear difference in the prevalence of prescribing, although it had some differences in the classes prescribed, but that overall older age and mechanical ventilation was associated with higher antibiotic prescribing in this population. So just wanted to review some strengths and limitations of our work. So strengths, large number of studies, wide geographic region, and doing the meta-regression, helps to quantify some of the risks of co-infection and prescribing based on study factors. We think there's helped identify some opportunities for antibiotic stewardship. Some of the limitations we want to acknowledge are that there was a high degree of heterogeneity among the studies, especially differences in methods for bacterial detection and even just the detail provided on methodology. Definitely there was challenges in distinguishing true infection from colonization. Many of the studies reported microbiology findings, but didn't talk about clinical. And so that could be a limitation to think about. Again, there was a low number of studies reporting on copathogens, so it was really hard to make any sense of the numbers that were provided for the small number of studies. And then finally, the details about antibiotic use were lacking. So it's hard for us to differentiate between the antibiotics that were used empirically on admission versus for secondary infections later in hospitalization. There was also, although we have information on initiation of antibiotics, there was very few details about duration, for example. So really lots of opportunity to understand this, the prescribing practices more. Our next steps is to update the bacterial infection, co-infection in COVID-19 living review. And so we've done an updated search and the number of studies has really exploded. So we screened over 25,000 studies and have identified now approximately 100 to 150 for inclusion. And so now we're at the stage of extracting these studies, the data, and so hope to have results shortly. We know from the last few months that there's been increased interest in whether cortical, or how, I should say, corticosteroid use and tocilizumab use might interact with increased infection risk. So we've included that in our update and hope to have some specific findings on those. And then again, we'll be completing a meta-regression to evaluate the predictors of bacterial infection in patients with COVID. And as well, we will also be adding a quality assessment aspect to our update. So with that, I'm going to turn it over to Brad to talk a little bit more about the stewardship aspect as it relates to our findings and the COVID-19 pandemic in general.
Great, thanks so much, Val. So yeah, let's talk a little bit about the implications of COVID-19 to antimicrobial stewardship. On the next slide, you see, thinking about our initial question that Val had posed to you, what is the impact that COVID-19 will have on antimicrobial use and antimicrobial resistance at a population level? So next, can you shift to the next slide, please? So firstly here we have a few studies that are in the hospital setting looking at antimicrobial use relative to the onset of COVID-19. So the first study at the top here is by Vaughn and colleagues, is a large network of hospitals in Michigan. And their findings were quite similar to ours that Val had just presented. Essentially, that they found very high antibiotic use. But this study gives us some additional granularity that we weren't able to look at in our study. So for example, they found empiric antibiotic duration tended to be about 3 days, which is relatively short. But more problematically for those patients who went on to have a lack of confirmed bacterial infection, so they did not have a bacterial infection, 65% of those went on to receive more than 5 days of therapy. So this gives us a sense that antibiotic use in COVID-19 is not necessarily just empiric, and it may continue on longer than is needed. So there's certainly an opportunity for stewardship there. So from a broader hospital perspective, the second row here by Burrell and colleagues, from a single center Veterans Affairs Hospital in Pennsylvania, they found that although antibiotic use and the number of patient days went down, the intensity of antibiotic use went up. So the antibiotic days of therapy increased by about 8.1 days of therapy per month. And then finally in a hospital, a single center hospital in Spain, they found similar findings with a biphasic increase in antibiotic use after the onset of the pandemic. So initially it was oral antibiotics, specifically amoxicillin and clavulanate. And then they found a higher increase in broad spectrum, what they call broad spectrum antibiotics as anti-pseudomonal agents that were typically used in the ICU as a result of their local recommendations to use these antibiotics in patients with COVID-19. So that's the hospital kind of story from a few selected studies. But on the next slide, you'll see that it's kind of a different scenario. Kind of go back a little bit. Yep, perfect. One more. Yeah, so the situation in the community setting appears to be quite a different story. So several very large population-wide studies in Scotland, Canada, and the United States found reductions in antibiotic use on the order of about 30% following the onset of the pandemic. And these decreases in antibiotic use, as Val alluded to earlier, could be driven largely by decreases in respiratory antibiotic use. And so the reasons for this are still yet to be determined, but it could be due to the decreases that we saw in terms of other respiratory infections other than COVID-19, like influenza and the common cold. So less use of antibiotics for situations where they shouldn't have been used in the first place. But it also could be due to less care seeking for patients who have respiratory infections during the pandemic. So on the other hand, at the bottom of the slide, a study by Shaw and colleagues found that dental antibiotic prescribing may have increased in some settings due to restricted access to dental care during the pandemic. So in the United Kingdom, dental prescribing increased by about 25% following the initiation of the pandemic. And again, this likely reflects inappropriate prescribing given the importance of surgical management and the lack of role for antibiotics in managing most endodontic infections. So with all this to say, we don't really know the general direction in which antimicrobial use and antimicrobial resistance will be pushed as a result of COVID-19, but it's likely that it's going to be specific to the context, and the hospital setting may be of a greater concern. So next slide. So we've given you some information about the challenges with respect to antibiotic overuse in COVID-19. But before we move on to some recommendations, I have a poll for the participants. So what approaches do you think we can use to help reduce antimicrobial use in COVID-19? So think about avoiding empiric antibiotics in low risk patients, reevaluating antibiotic use at 48 hours, restricting antibiotic use in COVID-19, or all of the above, or just A and B. So I'll give you about maybe 10, 20 seconds to complete that poll. Okay, so perhaps we can pull up the results of the poll now. Okay, so really interesting to see. A and B is the most common response, 64%, and then all of the above. So those of you who said A and B, that would be the most correct answer. It's certainly reasonable to avoid empiric use in patients who are low risk for bacterial infection. And we saw that that's a lot of patients generally tend to be low risk for co-infection. It's appropriate to reevaluate antibiotic use at 48 hours in those who have started antibiotics. But restricting antibiotics is not always a feasible approach, given that we know that antibiotic use will be necessary in some patients, although it should be fairly infrequent. So next slide. So what do the guidelines say for antibiotic prescribing in patients with COVID-19? And certainly, as Val alluded to, this is not an easy task. It's not always easy to know who should be getting antibiotics. The clinical picture is not always clear in terms of differentiating those who have bacterial infection from viral infection from both. Certainly things like rapid diagnostic testing can be useful to help speed up the time that we know what the causative pathogen is, if any. But what do we do in the meantime while we're waiting for test results to come back? So from a guideline perspective here, I've summarized what most of the local and global guidelines say on this topic. And you can see with the red X's, which is situations where antibiotic empiric prescribing is not recommended in those situations. There's really consistency across the guidelines that for most patients with mild to moderate COVID-19, that means patients in the outpatient settings or those who are in the hospital but not critically ill. Those patients should generally not be receiving empiric antibiotics unless we know with a high level of certainty that there are bacteria involved. So the situation gets a little bit more controversial when we look at critically ill patients. As we saw, the risk for co-infection or secondary infection can be a little bit higher in these patients. This is probably less so because of COVID-19 itself, but more so because of hospital-acquired infections like ventilator-associated pneumonia. And due to the acuity of their illness, timely antibiotics for those with true infections can really help to improve their outcomes. So that's why you see a little bit of uncertainty from guideline to guideline in terms of what the right thing to do is in critically ill patients. So for the WHO and the Surviving Sepsis campaigns, they do give it a yes for recommending empiric antibiotics in patients with COVID-19. But on the other hand, guidelines from the UK, the NICE guidelines, as well as our Ontario clinical practice guidelines do not recommend antibiotic use unless bacterial infection is strongly suspected, such as the patients having characteristic signs and symptoms of a bacterial infection like localized findings on radiography. And then there's the Dutch Working Party guidelines, which kind of hedge a little bit and say, we generally suggest restrictive use of antibacterial drugs in patients with proven or high likelihood of COVID-19, but this especially applies for patients who are mild to moderately ill. So kind of a little bit of uncertainty of what to do in those critically ill patients. So next slide. So a little bit more focusing on the local recommendations in Ontario. We do have Ontario-wide guidelines for managing COVID-19 in terms of antimicrobial and immunomodulatory therapy. These guidelines lean away from empiric antibiotics. So just one more click and we'll zoom in on the antibacterial recommendations. These guidelines generally lean away from empiric antibiotics in critically ill COVID-19 unless there is a concern for bacterial co-infection. So in those with mild to moderate illness, if COVID-19, if you're waiting COVID-19 or you know that it's a COVID-19 positive patient and there's no evidence of bacterial pneumonia, then no antibiotics would be necessary for those patients. So next slide will give you a little bit more detail in terms of the breakdown of the different recommendations to consider. And this is from the Dutch Working Party guidelines. So they recommend avoiding antibiotics in patients that have a high likelihood of COVID-19, especially in those with mild to moderate illness. That is considered a weak recommendation with generally low quality of evidence that we have so far. However, they do recommend to give empiric antibiotics if radiographic findings of co-infection exist or the patient is severely immunosuppressed. And again, this is a weak recommendation. They do state if starting antibiotics, you need an exit plan. So we don't want to just start antibiotics and have them continue indefinitely. They strongly recommend doing sputum cultures and blood cultures before starting antibiotics, so we can reevaluate shortly after initiation. The guidelines do not recommend atypical coverage unless there's a strong suspicion for Legionella in that patient or in that hospital. And if they say that if sputum and blood cultures are negative, it's reasonable to stop antibiotics at 48 hours. And for those who do require antibiotics, 5 days of therapy is a reasonable duration of therapy. So next slide, please. Most of the recommendations that I've spoken about so far really focus on hospitalized patients. So how about those patients who are in the community? And Choosing Wisely Canada has some great recommendations for managing respiratory infections, particularly in the era of COVID-19, including which criteria would warrant an in-person visit versus a telemedicine visit, and which criteria would warrant antibiotic use. So for example, in outpatients with suspected or confirmed COVID-19, if they have fever, respiratory symptoms, but no shortness of breath, a virtual visit is entirely reasonable. However, those who do have shortness of breath, concerns for bacterial infection, or any red flags such as chest pain or dizziness, an in-person visit would be suggested. And these recommendations go on to explain and reinforce the fact that there is really no role for antibiotics in the outpatient setting for patients with COVID-19. So these are really great practical recommendations, and they cover a number of other respiratory infections as well. So I encourage you to take a look at those when you have some time. So next, let's apply some of this information to a patient case, a fairly typical type of patient case. So this patient is a 56-year-old male with a new fever and a productive cough. Past medical history is significant for hypertension. And on exam, that you find that the patient is saturating well from an oxygenation perspective, 97% on room air, and respiratory rate is 22 per minute. The patient does have a fever at 38.6, but is not in any respiratory distress. A white blood cell count is 7.4. And on imaging on a chest x-ray, you find that the patient has bilateral ill-defined patchy opacities in all lung zones. And the patient has been ordered an NP swab for COVID-19 and influenza, and these results are pending. So I guess think a little bit about how you would manage this type of patient. This is not a poll question, but more of kind of a self-reflection question. But in general, we would think of this patient as one who has mild COVID-19. There's really no evidence of bacterial pneumonia based on the information provided here, based on the radiographic findings and the white blood cell count, for example. So it would be recommended to withhold antibiotics in this patient. And even those patients who are moderately ill with a similar presentation, really withholding antibiotics to reduce the risk of side effects, reduce the risk of C. difficile and antimicrobial resistant organisms that may be selected by unnecessary antibiotic therapy. So next slide, in conclusion, we've shown that COVID-19 does present a potential risk for worsening antimicrobial resistance, and it seems like the majority of those watching believe that there is certainly a risk that AMR will increase as a result of COVID-19. We found overall that bacterial co-infection tends to be fairly infrequent or uncommon in COVID-19 patients. But on the other hand, antibacterial prescribing is quite high, at least 70 to 75%. So we need to make sure that we take efforts to improve the quality of antibiotic prescribing in these patients. Most notably, avoiding empiric antibiotics in patients with COVID-19 unless there is clear evidence that the patient has bacterial pneumonia, or they're severely ill or immunocompromised. And then if prescribing of antibiotics is necessary, blood and sputum cultures should be performed prior to antibiotic treatment. And antibiotics should always be reassessed at 48 hours, whether it's in the setting of COVID-19 or not, and discontinued if COVID-19 is positive and blood and sputum cultures are negative. So that concludes our presentation. We do have some references that will be made available after this presentation, probably in the coming weeks. This will be available in both French and English. I'll pause there. I think we're happy to take any questions.
So thanks, Val and Brad. That was a great presentation. We are going to move now to the Q&A pod. For people who haven't had a chance to enter questions into the pod yet, please continue to do so. I'm going to take the first question, and my question is, what are some of the practical things healthcare workers can do at their hospitals right now to help improve antimicrobial stewardship during COVID-19?
Yes, thanks, Jenny. I think that's a really important question, and I've done similar talks with other hospitals, and one of the main key messages that comes up as a result of this discussion is how can we impact patient care from a broader systems-wide perspective. And one opportunity that many have thought about is reevaluating order sets and pre-printed orders, whether they be electronic or not, that are geared towards COVID-19 patients. So many hospitals may have COVID-19 order sets that include antibiotics in them. And this is an important opportunity to decide, how do you frame those recommendations for antibiotics? Do you even include antibiotics in those order sets, or make it very clear that there are specific criteria in which antibiotics would be prescribed? That could kind of make a difference at a hospital-wide level to prevent antibiotic overuse. Another approach, and many hospitals have done this, is to flag those patients who are COVID-19 positive, and potentially even look at flagging the overlap of patients who are COVID-19 positive and on antimicrobials as a potential issue for inappropriate antibiotic prescribing, and specifically targeting those patients. So those are a couple of things that could be done in a rather short period of time, but certainly require buy-in from others in order to achieve those strategies. But I'll see if maybe Val wants to add anything as well.
I think you've covered most of the important points. Thanks.
Okay, so our first participant question comes from Rohit, and his question is, during COVID-19, steroids were prescribed. Does that contribute to overprescribing for antibiotics for prophylaxis?
Yeah, so certainly there's some evidence that steroids can help to improve outcomes in patients with COVID-19, specifically patients who are requiring respiratory support or oxygen therapy. And because of that, there's potential risk that patients could be immunocompromised and a higher risk for potential infection or secondary infection. So this is one of the things that we're hoping to look at in our next review on a rapid review, is to be evaluating studies that included patients who are receiving corticosteroids, and to see if this has, at a population level, see if this has an impact on the rate of co-infections in those populations. But despite the high use of corticosteroids in many of the infections, or many of the COVID-19 infections, we're still not seeing very high rates of bacterial co-infection in those patients. But we'll keep an eye on this, because as we get more data, it will be later on into the pandemic, and as we know, corticosteroid use did start to increase as the evidence became available. So we may begin to see a bit of a different picture as time goes on. But yeah, it's certainly an important point to note that corticosteroids can increase the risk for co-infection in patients.
Okay, the next question comes from Boys, and it says, looks like overall reduction of antibiotic use is driven by decreased care provided, but if calculated by rate or 1,000 patient days, it increased. Is this assumption right?
Yeah, so in one of the studies that I had showed, which was a specific hospital, was a single center study, they found that antibiotic use actually decreased, but also the patient days decreased. But when you take the ratio of the two, they found that the intensity of antibiotic use increased, so which is still problematic. This is not necessary to say that this is something that is applies to other settings as well. In the community, as you saw, it's a different story where antibiotic use and patient visits both went down. So yeah, it's important to take into account the intensity of usage, but also the overall volume of use. So that's why that study kind of reported both of those metrics.
Okay, next question is, from a knowledge translation perspective, what thoughts do you have on curbing current unnecessary antibiotic prescribing in acute care for hospitalized COVID patients?
Yeah, I think this is a great question. It kind of really aligns with the first one that you had posed, Jenny. So I think, yes, things like reevaluating your order sets, looking at ways that you can flag patients who are COVID-19 positive and also receiving antibiotics are some key approaches that can be used, I think.
Great. So our next question comes from Gary Garber. Hi, Gary. Nice to see you online. And his question is that since 90% of COVID tests are negative, how sure are you that a presentation of moderate pneumonia is actually COVID-19 prior to results? Shouldn't the emphasis be to stop empiric antibiotics when COVID is identified?
Mm-hmm. Yeah, I think there's a couple of points here, and it's a really good point, which kind of underlines why this is a particularly difficult issue. From the outset, it's hard to say if any given patient has COVID-19 or a bacterial infection or both. We know that both is quite unlikely, but from an empiric perspective, we know that both is unlikely because we saw that the rate of co-infection is probably less than 5% in most patients. So co-infection should not be anticipated. But if the patient has signs and symptoms that are typical of a bacterial pneumonia, outside of the context of COVID-19, we have this issue as well. So things like, radiographic changes, so localized globular infiltrates, using laboratory values such as white blood cell count, looking at patients' symptoms and auscultation and things like that. None of those are perfect, but they can help to improve your likelihood that you're dealing with a COVID-19 infection or a bacterial infection, in addition to the epidemiological risk of the patient as well, like have they been in close contact with a case or are likely to have COVID-19. So there's certainly a lot of factors involved, and definitely one of the biggest things that we can do is reevaluate antibiotic use at say 48 hours. And what a lot of stewardship programs do is called an antibiotic timeout. So 48 hours, you look again and you say, okay, COVID-19 is positive. The chest x-ray is not showing any signs of worsening or localized infiltrates. It's reasonable to stop the antibiotics that we initially started. But I think if we, in the context of very high community circulation of COVID-19, to start empiric antibiotics on every patient who has suspected COVID-19 versus pneumonia could be very problematic and leads to very high antibiotic use. So that's why I think it's quite reasonable to avoid antibiotics in mild to moderate cases who have a very low clinical suspicion of CAP. But yeah, it's certainly a very challenging question. And yeah, thanks for asking that.
Okay, next question. In terms of antibiotic stewardship, especially during COVID-19, what is being done to educate health professionals? Previous studies regarding education of health professionals have shown various practices and experience regarding prescribing.
Yeah, thanks for that question. And I think both Brad and I will admit that during COVID, we've been inundated with other workload, and that's true of other education things that we have been put on the back burners with respect to stewardship in general. But some of the work that we've done in sort of more passive knowledge translation, we have heard from different groups that our rapid review has informed some of the prescribing practices out there with regards to COVID in hospitals specifically. And Choosing Wisely has done a great job in putting together some of those algorithms, especially in the face of virtual visits, which presents a very different scenario, I think, than what we were used to before, and we knew could have some impact on antibiotic prescribing. So I think, it's kind of a roundabout way of saying that, I think unfortunately we haven't really had as many opportunities to do that direct, interactive type of education. But we did try to incorporate some more passive knowledge dissemination translation style ways of really trying to push that message forward. I don't know, Brad, if you wanted to reflect on some of the feedback you've heard, both here at home and internationally, on some of the work that we've done around co-infection.
Yeah, I think even just something as simple as the visual abstract that we prepared has kind of made its rounds on the internet and in hospitals and different settings across the world as a kind of a helpful reminder for clinicians to have this discussion. I have heard just informally that our work has kind of helped to inform some discussions with providers about antibiotic overuse in say, for example, internal medicine patients. So I think that's kind of a helpful approach from a knowledge translation perspective, is to have the information available both in text form and visually to help kind of further support that messaging.
Okay, so another question from Gary, and his second question is, are you looking at hospital antibiotic use comparing the first wave where data was not clear of bacterial co-infection versus the second or third wave? Is there a learning effect?
Yeah, thanks, Gary, for that question. I think that in our rapid review, the second one, we did see over time from April even to June that the prevalence of antibiotic prescribing, and that was mostly in hospitalized patients, was decreasing. Now, this of course is maybe not, it's not very granular. Like, you just get a sense of the initiation. You don't really know the duration, or is very little information about the selection even of the antimicrobials. So definitely it's an area we would like to look further at, maybe locally in Ontario when we do our biannual survey of antibiotic use, because we would like to track that over a month if we can. But I think there has been a learning curve in terms of empiric use, but it would be interesting to know sort of the more overall impact with respect to duration of therapy, whether people have been actually reassessing at 48 hours as the pandemic progressed more often. Brad, I don't know if you had anything else, reflections on that.
Well, nothing to add. That was perfect.
Okay, so next question is, with the antibiotic prescription, are we concerned about fungal infection?
I guess the short answer is yes, and especially with respect to some of the treatments that we're using now for COVID, such as tocilizumab. But unfortunately for our reviews, that was considered out of scope, and we didn't really look at that and didn't capture it. It wasn't that many studies, but probably that's also an area of interest for some, and I think there's more opportunity to look at that. I don't know, Brad, if you had more on that.
Yeah, as Val mentioned, it was out of scope for us to look at fungal infections, but others have done similar reviews on this and found that overall the rates of fungal infection are relatively low. There are certainly some concerns in patients who may be at higher risk for fungal infection. So, for example, patients who are receiving immunosuppressive therapy, those in the ICU, those with community exposures, for example. So it's not something that we particularly looked at, but I think it is a concern, but relatively low in comparison to the other outcomes associated with COVID-19.
Okay, next question is, do you have any data whether transition to virtual care has increased antibiotic use overall in primary care settings?
I can take this. It's something that we kind of presented very briefly in our presentation, that there is some data from the Public Health Agency of Canada towards, I would say, the summer of 2020, looking at antibiotic use from 2019 to 2020. And we found in the primary care setting that antibiotic use had actually decreased by about 30% during the first few months of the pandemic, and it seemed to kind of stay low. We don't have data later on in the pandemic to see if it had rebounded, but that's something that we're hoping to look at in Ontario. So yeah, there definitely was a shift towards virtual care, but as we also mentioned, potentially less care seeking in general, and other factors like physical distancing, hand hygiene, masking, that may have had an impact as well on respiratory infections that generally get antibiotics in the primary care setting that may not necessarily need antibiotics. So there was a lot of factors that did result in that shift and decrease in usage in the primary care setting.
Okay, next question. It says, I wonder if efforts to treat, manage COVID patients and ever-changing guidelines across the world could have contributed to overuse of antibiotics.
Such as macrolides, I see Rohit wrote. I'm not sure. I think that's a good question, and I don't really know. I mean, Brad presented some guidelines that talk to this, but certainly that's not comprehensive. And in other regions of the world, there may be different approaches to that. So I think it'll be interesting to see with our update, because there's way more. I think so in the earlier RACA review was heavily focused on sort of what Asia was doing, because that was where the pandemic was emerging from. But I think it'll be interesting to see what we find as we update the review with more articles, and I think more variability in the geographic regions that will have studies coming out of it. So I think that, yeah, it'd be interesting to see whether the rates are same or will change over time. Like, we think it's going lower, but yeah, I think that's remains to be seen.
Okay, next question. Considering that making a microbiological diagnosis of community-acquired pneumonia is low at the best of times, sputum cultures not being sensitive, do you feel these co-infection rates are an accurate reflection?
Yeah, that's an excellent question. I think it's one of the limitations that we've highlighted from this work, is that there's a potential that you could undercall the likelihood of bacterial co-infection, because, as you mentioned, the lower sensitivity of sputum cultures, the fact that not all patients who come into the hospital with a concern for community-acquired pneumonia actually get sputum cultures. For that reason, we also included blood cultures when they were available as well. Granted, that's not perfect as well. Not everyone who has a true bacterial pneumonia will have positive blood cultures. But on the other hand, there's a potential risk that you could be overcalling pneumonia too, because some hospitals use sputum cultures, let's say, indiscriminately without the correlation clinically to say that this patient in fact has true bacterial infection versus a colonization with those organisms. So I think there's a possibility that we could go either way in terms of overcalling versus undercalling. And in the absence of better approaches to diagnostics, I think this is a limitation we just have to kind of acknowledge at this point.
Okay, next question is, do you think vaccination can have an impact on AMR trends antibiotic use?
I think it's one of many factors, just like that first slide we showed with the with the sort of different bullets. Like I think that if we are seeing that hospitalized COVID patients are receiving lots of antibiotics, then if we decrease the number of people coming to hospital with COVID, we're going to have less. But then, you know, as we maybe come out of into a recovery phase where we go back to sort of, you know, doing the things that we were doing before, is that going to, you know, kind of increase antibiotic use in other areas? I'm not sure, Brad.
I think there's a lot of factors at play, but certainly vaccination is, you know, I'm hopeful that I think that's going to have a big impact that will help us reduce the risk of overprescribing for patients who have COVID-19. Because obviously we're already seeing the results of vaccination here in Ontario with decreased case counts. And so, yes, antibiotic you know, use is going to probably go up for other reasons. But from this perspective of COVID-19, I think it's certainly a good thing.
Yeah, I think, you know, if we were talking about unnecessary antibiotic use, yes, I think vaccination for COVID could definitely reduce unnecessary antibiotic use in the context of COVID.
Okay, and looks like there's a question if you have any recommendations for nursing homes. Not sure if.
Yeah, thanks for asking that. I think that's certainly an important population that we definitely don't want to overlook. I just typed something into the answer pod. I'm not sure if you got that. I'll put it into the question and I'll put it into the chat pod as well. That basically has recommendations that are Ontario-wide and do not specifically say it's for one setting or the other. So they apply to ambulatory patients, those in long-term care settings, as well as those in hospital. And so most patients say if they do develop COVID-19 in a long-term care home setting, perfect. PHO events just shared that. Most patients who develop COVID-19 in a long-term care home setting who either don't require oxygen or require a little bit of oxygen but not transferred to hospital for critical care, the risk for bacterial co-infection based on our rapid review is low in those patients, and empiric antibiotics would not be necessary unless there's a strong suspicion that that patient has a bacterial infection, like you've seen something on a chest x-ray, or they have a very high white blood cell count, or something that really is indicative of a strong suspicion for pneumonia. So yeah, hopefully those recommendations are helpful to you in the long-term care setting.
Okay, so that's all our questions in the Q&A pod. So as we wrap up today's PHO round session, I would like to thank Valerie and Bradley for presenting. I would also like to thank everyone who joined us for today's session. It's great to see such strong virtual participation during such a challenging time for healthcare professionals. To access past PHO rounds presentations and view confirmed upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Lastly, you can expect to receive a brief and an anonymous PHO round survey for today's session shortly. Please try and complete this to help us improve our programming. Thank you and have a wonderful day.